Hello friends, today we will see newer modes of non-invasive ventilation. In this module, we will see about C-flex, A-flex, C-flex plus, volume assured pressure ventilation, that is VAPS, and adaptive servo ventilation. These three topics are important topic we should know because newer machines are coming with this mode and we should know where to use, how to use, when to use, and in whom to use. So on NIV, I have made a lot of videos previously, start from basic physiology to NIV in respiratory failure. So you can check on my YouTube channel. So it is important. So now coming to first mode, that is C-flex. In Philips company, it is called C-flex. In ResMed company, it is called expiratory pressure relief. Both things are same, mechanism are same, but name is different by machine Philips, C-flex, and by ResMed expiratory pressure relief. So if you remember my previous class, what happened in OSA, we are giving CPAP. In CPAP, we are giving constant pressure, same pressure while inspiratory phase, same pressure while expiratory phase. In both phase, we are giving same pressure in CPAP. But many patient, they doesn't tolerate. Can you imagine somebody is that keeping mask and that pressure is releasing by this machine while inspiration, okay, patient can inhale, but while expiration, it is really difficult to exhale against pressure which is being delivered by CPAP machine. So CPAP machine inspiratory is comfortable, but expiratory phase is uncomfortable because patient has to expire against pressure. So for this purpose, we can reduce pressure at the beginning of expiratory phase. If we reduce expiratory phase pressure, then patient can exhale comfortably. So depends on patient tolerance. It has three level 1, level 2, level 3. If patient is intolerant, highly intolerant, we can set level 3. So it will reduce pressure more in beginning of expiratory phase. If patient is mildly intolerant, then we can keep pressure 1. So depend on patient comfortability, we can set 1, 2, 3. But in this mode, pressure at the end of expiration will be normal. So what pressure which is being delivered in inspiratory phase will be same in end expiratory phase. But beginning of expiratory pressure will be lowered. So this is C flex. Same mechanism happened in AutoPAP. Okay. AutoPAP, you can see this graph. In this graph, you can see pressure is less, more pressure, medium pressure. So in AutoPAP, pressure is being changed constantly depending on patient requirement. If patient require high pressure, it will deliver more pressure. If patient required less pressure, it will deliver less pressure. This is AutoPAP. Okay. So in AutoPAP, you can see, yeah, this is inspiratory phase. In expiratory phase, pressure is reduced as compared to inspiratory phase. But end of expiration, pressure is normal. In this also, at the beginning of expiratory phase, pressure is reduced with three level. So this is C-flex or expiratory pressure relief in ResMed company. So what is another thing is A-flex or C-flex plus. Okay. So previously what C-flex, this is C-flex plus. So additional thing is there. What is additional? In previous mode, coming from inspiratory to expiratory, there is sudden lowering of pressure. But in C-flex, pressure is coming smoothly. So the smoothing of transition between end of inhalation and beginning of exhalation. So this is smoothness from inspiratory to expiratory. This is C-flex plus. Another thing is level is same 1, 2, 3 depends on patient comfortable level. But one thing is you have to remember that in previous mode at the end of expiration pressure become normal, but in this mode pressure at the end of expiration is lower. How much lower? It is less than 2 centimeter. So say for example, if we set 8 pressure here, then it should be 6 or more than 6. So expiratory phase is more comfortable as compared to C flex, previous one. Here it is more comfortable because at the beginning of expiration pressure is lower, and expiratory phase also pressure is lower. So this is C flex. So three things are there: smooth transition from inspiration to expiration, beginning of expiration is lower pressure, and end of expiration is also lower pressure. So this is C flex plus. If we see in AutoPAP it is called A flex. This is C flex in conventional CPAP. In AutoPAP it is called A flex. So you can see this graph, pressure is different. In this breath is different, this breath is different. This is AutoPAP. In AutoPAP, A flex, you can see transition from inspiratory to expiratory is smooth, and beginning of expiration it is smooth, and at the end of expiration pressure is lower. This is A flex. So A flex is in AutoPAP, but C flex plus in conventional CPAP. Both mechanism are same, but name is different. So this is C flex, A flex. Now coming to another mode, that is VAPS, volume assured pressure support. This is new technique which is there in new machines, and this is frequently asked question in your DM exam and MD or DM final year exam. VAPS. What is VAPS? As name suggests, volume assured pressure support. In this machine will assure that volume delivered is constant to patient. So whatever volume we are setting, it will be delivered to patient. If we are setting full liter per minute, it will deliver to patient full liter, not less than that. That is volume assured. Okay. So in this machine, we will tell machine that you have to deliver set tidal volume. Say for example, 500 ml. This machine will deliver 500 ml. If we set alveolar ventilation, say for example 4 liter per minute, it will deliver 4 liter per minute. So this will give guarantee of a minute ventilation. In case of, so where to use? In case of hypoventilation. Suppose patient is sleeping, patient getting hypoventilation, then normal, then hypoventilation. So ventilation is changing. So in that case, we can use this mode. So this will assure, or this will give guarantee of a constant tidal volume or constant minute ventilation. So what are the indication? Overlap syndrome. Patient OSA with hypoventilation, where CO2 is getting rise because of hypoventilation. Alveolar hypoventilation, maybe because of neuromuscular or restricted lung disease. When patient is not getting enough tidal volume or enough minute ventilation, then this mode is helpful. So as I told you, it will give guarantee of delivering a constant tidal volume or minute alveolar ventilation. So what we have to set, either tidal volume or alveolar ventilation, depends on what machine. So I'll tell you next slide. Then expiratory positive airway pressure, because this is help in OSA patient. Okay, CPAP. Then minimum inspiratory pressure, maximum inspiratory pressure, because pressure is keep changing, depends on how much patient is generating tidal volume. If patient is generating less tidal volume, it will give increased pressure, IPAP pressure, because IPAP pressure delivering tidal volume. If tidal volume is high or more than required, then it will reduce pressure. So pressure, what we said, we said EPAP pressure, it will help in OSA patient, and minimum IPAP and maximum IPAP. So IPAP will reduce or increase depends on how much patient is demanding tidal volume or alveolar ventilation. So if ventilation requirement is more, it will give more pressure. If required less, it will give less pressure. So VAPS mainly two companies are making VAPS, especially in India. One is Philips and one is Resmed. Other Indian companies are also there, but I'll discuss these two modes, AVAPS and iVAPS. AVAPS is average volume assured pressure support made by Philips. Same machine or almost similar machine made by Resmed is intelligent volume assured pressure support, I-VAPS. So AVAPS, I-VAPS. These are two modes of VAPS by two different companies. So what is that? So first we will see AVAPS, which is made by Philips. So in this machine, we have to tell machine the requirement of expiratory tidal volume. So we have to set tidal volume. Say for example, patient needs 500 tidal volume. So the machine will deliver 500 ml tidal volume by increasing or decreasing iPAP pressure. Since for example, a patient generating 400 ml, then it will increase iPAP pressure to make 500. If it is generating 300 ml only, then it will give further increase in iPAP pressure to deliver 500 tidal volume. If patient is generating 500 ml already, then it will give constant pressure. If patient is generating 550 ml, then it will reduce iPAP pressure. In nutshell, this machine will give guarantee tidal volume by changing iPAP pressure. Okay. And one thing is that iPAP pressure is changing by 1 centimeter or go up to 5 centimeter water. Say for example, if patient is getting hypoventilation or less tidal volume, it will increase pressure. It can increase 1 centimeter of water or go up to 5 centimeter of water. So how much it should increase? What the rate it should increase? So we can set in certain device that machine should increase pressure by 2 centimeter of water or 3 centimeter of water up to 5 centimeter. It's called VAP rates. So VAP rate is nothing but the rate of increased pressure by breath when patient is getting hypoventilation. This is rate. We can set called VAP rates. Another thing is auto adjusting EPAP. If patient is getting apnea or hypopnea, then it will give increase EPAP pressure. That is CPAP pressure. This one, CPAP pressure. Okay. If patient not getting apnea, hypoventilation, hypopnea, apnea, it will reduce EPAP pressure. The auto adjusting, like a AutoPAP. Another thing is we can set respiratory rate by auto mode. Means you press auto button, then machine will calculate the requirement of respiratory rate of patient by previous data. Okay, say for example that patient normally, when patient is awake or patient is normally breathing, respiratory rate is 16. The machine will feed in his mind that patient used to require 16 breath per minute. So when you set auto mode, then machine will give 16 breath only. If patient is generating uh, uh, 12 breaths, then it will give additional 4 breaths. So this is auto adjusting respiratory rate. So what we are setting? We are setting the tidal volume, we are setting VAPS rate, we are setting EPAP, we are setting respiratory rate. This is auto set, intelligent mode. It can increase or decrease depends on patient requirement. This is average volume assured pressure support. The company Resmed made I-VAPS. Intelligent. This is intelligent. Okay, this was average. So in this previous machine, we were setting tidal volume. Here we are setting alveolar ventilation. As we know, alveolar ventilation is minute ventilation minus dead space ventilation. So how to calculate dead space ventilation? It depends on height. More is the height of patient, more is the dead ventilation. Okay. So you feed height of patient in machine. Say for example, 165 centimeter. So machine will calculate dead space ventilation itself. Okay. So it will minus from minute ventilation. it will calculate alveolar ventilation. So we have to set alveolar ventilation in machine. Say for example, 4 liter per minute. We will tell machine that kindly deliver 4 liter per minute to this patient. Okay. So to deliver 4 liter per minute, the machine will adjust pressure support. Okay, from minimum to maximum. If patient generating 3.5 liter per minute, it will give little pressure. If it is generating 3 liter, it will increase pressure. If it is generating 2 liter, it will further increase more pressure to deliver 4 liter. But it will give guarantee that patient will receive 4 liter per minute of alveolar ventilation. Depends on patient generating how much volume. Okay, then backup rate. This also auto adjustable. So machine will calculate 2/3 of baseline spontaneous rate, that is target patient rate. Again, auto adjusting EPAP to maintain upper airway patency to relieve OSA, obstructive sleep apnea. If patient is having apnea and hypoapnea, it will give more CPAP. Then another thing is learn target. This is a key mode in this machine. By pressing learn target, then machine will calculate automatically how much pressure patient is requiring, how much respiratory rate patient is requiring. So you have to just set learn target. Machine will identify how much alveolar ventilation and how much respiratory rate patient is requiring. So we have to do nothing. Machine will calculate. So this is complete intelligent mode. That's why it is called intelligent VAPS. So machine will increase or decrease pressure depends on how much ventilation you have set. Now another newer mode is called adaptive servo ventilation. This is very important for your exam purpose. Okay, adaptive servo ventilation. So what the indication? It is used in chain stroke breathing secondary to systolic heart failure or diastolic heart failure. So any heart failure which is causing chain stroke breathing, we can apply adaptive servo ventilation. Another is chain stroke breathing secondary to long acting opioids. Those patients who are taking long acting opioids, in them, if patient develop chain stroke breathing, we can use adaptive servo ventilation. Another indication is treatment emergent central sleep apnea. So if you are giving CPAP for OSA, in these patient may develop central apnea. That is called treatment emergent central sleep apnea. That we can use adaptive servo ventilation. So what is chain stroke breathing? In chain stroke breathing, there is hypoventilation, hyperventilation, then apnea. Means crescendo, discrescendo, ventilation, then apnea. So you can see this is apnea part. The patient ventilation is increasing, and increasing, hyperventilating. Then start hypoventilating and goes for apnea. So gradual hyperpnea, hypopnea, then apnea. This is chain stroke breathing. So if you see mechanism how chain stroke breathing develop in congestive heart failure. In congestive heart failure, because of low cardiac output, there is venous congestion to pulmonary vessels, pulmonary venous circulation. As we read in our MBBS day, there are J receptors present in interstitium. Okay, so what they do, if they sense more fluid in their receptors, they will cause hyperventilation. Okay, so J receptor activation, they trigger hyperventilation, and because of hyperventilation, CO2 will wash out. Hypoventilation, more CO2. Hyperventilation, CO2 wash out. And CO2 wash out, it will go below apneic threshold. So what is apneic threshold? The level of CO2 below which patient will have apnea. That is apneic threshold. Say for example, if baseline CO2 is 40, then apnea threshold would be 35. Means if patient is having hyperventilate, causing washout of CO2, and CO2 go below 35, patient will have apnea. So it will cause central apnea. When central apnea is there, means loss of ventilation. Then CO2 will rise again. And because of CO2 rise, again hyperventilation will occur due to venous congestion because CHF is there. Again hyperventilation, again wash of CO2, again apnea. In apnea, hypoventilation, raise CO2, then hyperventilation. So this theory causes crescendo discrescendo breathing pattern. Hyperventilation, then hypoventilation, then apnea. This is change stroke breathing. This concept is called loop gain theory. So what is loop gain? A small change in CO2 will cause more change in ventilation. Means COP in CO2 is getting this much rise, but ventilation is causing this much rise. Small CO2, but ventilation is much more. So what will happen? Little CO2 rise, more hyperventilation, CO2 washout, apnea. This is loop gain theory. The loop gain theory, what is that? Respiratory center overreact to change in blood gas level, leading to cycle hyperventilation and apnea. This is change stroke breathing. So, what adaptive ventilation does? It will make sure that patient will get same level of ventilation, but lower than that of normal. It will not cause hyperventilation. It will not let cause hyperventilation because hyperventilation cause apnea. So it will lower ventilation. So what will it do? It has three things. Auto EPAP. Auto EPAP for OSA patient. But means it will change expiratory pressure depends on how much pressure requirement for apnea and hypopnea. For OSA purpose, CPAP will vary. Auto CPAP. If apnea hypopnea is there, it will increase CPAP pressure. If there is no apnea apnea and apnea, it will reduce CPAP pressure. So it functions like a AutoPAP, auto CPAP. Then depends on ventilation, it will increase or decrease pressure for breathing, periodic breathing. Periodic breathing means when hypoventilation, hyperventilation. If it is hypoventilation, it will give more pressure. If it is hyperventilation, it will give less pressure. But it will not cause hyperventilation. So we have to choose net ventilation 90% of previous normal. We have to choose 90% only because we don't want to patient to have hyperventilation. We want to patient to have little hypoventilation because we don't want to raise wash out CO2 because hyperventilation cause wash out of CO2. We don't want to wash out CO2. We don't want cause to have apnea. So we are keeping 90% of net ventilation. For that, it will give pressure depends on how much ventilation patient is generating. If it is hypoventilation, it will increase pressure. If it is hyperventilation, it will reduce pressure. In case of apnea, it will give auto backup rate. We have to set that patient auto backup rate is 15 per minute. Respiratory rate is 15 per minute. If patient is having apnea, it will automatically give pressure. Okay, so for example, we set 15. Every 4 seconds, it will give pressure. If patient is having own respiratory rate, then it will not give automatic pressure. If patient is having apnea, it will give pressure. So this is auto backup rate. All three mode is called adaptive servo ventilation. So I hope I am clear. I think it's understood for you. So this is adaptive servo ventilation. So in this graph, you can see if patient is having only OSA, then it will give EPAP. It will give EPAP only to relieve OSA. If patient is having apnea or hypopnea, I mean hypoventilation, it increase pressure support. Okay, so it will increase pressure support in anticyclic manner. more hypoventilation, more increase in pressure. In case of apnea, central apnea, it will give pressure support as well as respiratory rate to relieve giant stroke breathing. So this is how ASV functions. But always remember, don't use ASV in congestive heart failure with low ejection fraction below 45%. Means don't use ASV in congestive heart failure with low ejection fraction. It will increase mortality. Whereas studies prove that if you use ASV in this subset of patient, there will be more mortality. So this is that's all about newer modes of NIV. If you like this video, please like, write a comment, and share with your friends. And if you are not subscribed to this channel, please subscribe. I have made lot of video on NIV. Please check my YouTube channel. So see you with another video. Thank you very much.